Welcome everyone to our Lunch and Learn session. My name is Mairead McGinn and I am the Director of Fundraising and Communications for Depaul, and I will be your host for today's event. I am delighted to be joined by Professor of Biochemistry and Immunology at Trinity College, Luke O'Neill. So Luke has been working with Depaul since 2019 and this year has come on board as an ambassador for Depaul Ireland and Depaul International. So Luke, we are delighted to have you here today. So without further ado, I will hand over to Luke for his presentation.
Great, thanks Mairead. Very happy to give you some words of wisdom, hopefully, and information. I'll just share my screen. Now, I'm very happy to be involved with Depaul, obviously. Delighted to be an ambassador. Fancy, where's my ambassadorial gown or whatever the ambassador wear? I'm very happy to be an ambassador and help Depaul. We've done a few things over the last couple of years, I guess. And I'm very happy to give a talk today about COVID. Obviously, it's the big thing that's on everybody's minds still. And I'm going to give you an update on where I think we're at this stage of the pandemic. We're still in the thick of it in some ways, as you would all know. But there's great grounds for optimism because of the vaccination campaign, obviously enough. I'm also very happy to answer questions, so don't hesitate. Any question is welcome of any kind. Be fearless in your questioning. I'll do my best to answer them. Obviously, I'm an expert on the immunology part of this disease. And to give you a bit of context there, I have been an immunologist for 35 years now, I suppose. I began my journey in London, where I did my PhD back in the 80s. And I worked on rheumatoid arthritis, which is an inflammatory disease. And you might wonder what's that got to do with COVID? Well, it's the immune system is what goes wrong in rheumatoid. And for unknown reasons, your own immune system attacks your joints, makes them sore and swollen. You've all be familiar with arthritis, I would say. But it turns out there's a whole range of inflammatory diseases. And it's everything from arthritis to things like psoriasis in your skin, say, or MS in your brain, or Alzheimer's, Parkinson's. They all have inflammatory components, which means that the immune system, for some reason, goes out of control and begins to beat up your own tissues. This is exactly sort of a reasonable description of these things. And then the link to COVID is an inflammatory disease of the lungs, where the immune system again goes into overdrive, in this case in response to a virus, of course. We have no idea what causes Alzheimer's or Parkinson's. All we know is the immune system is out of control there. We know what causes COVID, it's a virus. And the virus, in a percentage of people, will cause inflammatory injury in their lungs and in their hearts, and then sadly this can cause fatalities, and severe disease. So as soon as COVID started, then many of us in immunology began to work on it. In my lab back March, 12 months ago now, I suppose, we switched over and we have 4 projects on COVID, the inflammatory aspect of it. So my lab doesn't work on vaccines, but we work on therapeutics, treatments to help people who get COVID and end up in hospital. But obviously, as an immunologist, I'm obsessed with vaccines for the past 30 years anyway. I have done some work on vaccines over the years as well. The part of the vaccine I work on is the bit that gets your immune system going. They're called adjuvants. And these are the components in vaccines that really drive an immune response. And all these vaccines that we have for COVID, it's remarkable, as you see. I'm going to give you a brief history of that. I mean, we can't believe really the success there. And somebody asked me a couple of weeks ago, what will be the legacy from COVID? One of them will be science has delivered, there's no doubt, because we have these hugely effective, safe vaccines against it. So I'm going to give you some of that history as well. Now, this next slide, just to give you an idea, I am an academic, so I have to show slides. I apologize. You've all been PowerPointed to death at this stage, I'd say, but academics can't resist. It is a battle that's being fought and for us to remember. And let's get my pointer going here. So never forget, it is about vaccines, of course. They're the main weapon we have against them. What vaccines do is quite straightforward. They're a piece of the virus, not the entire virus, because that might make you sick with the disease. So they're a piece of the virus, and that gets shown to the immune system. And now when the real bad guy arrives, the whole virus, if you like, the immune system can recognize it. It's a bit like you're showing the sheriff the black hat of the bad cowboy in a way. And then when the cowboy turns up with the black hat on, the sheriff can recognize him and eliminate him. And that's exactly how vaccines work. They're safe ways to drive immunity. Of course, natural infection will work as well and protect you, but the trouble is that causes death and disease. So vaccines are a safe way to provoke immunity, is the way to think of them. The second weapon are antibodies, and they're interesting because what the vaccines do is, or in fact, the normal infection brings out antibodies. And these are the attack dogs, if you like, of the immune system. They latch onto the virus and kill it. And of course, you can use antibodies as therapies. And in fact, 2 have got approved. a company called Regeneron, a very effective antibody cocktail, for instance. They're expensive, they're not the answer, but they can still be given to people in hospital. The third is drugs to kill the virus, direct antivirals. That's a really active area as well. And we have several drugs now, actually. One is approved. It's called remdesivir. That can kill the virus on contact, and it's useful. It does seem to decrease stay in hospital, for instance, which is a good thing. And then my part is the anti-inflammatories to stop the lungs from being harmed. And there's lots of drugs in development there as well. So never forget, we have these various approaches being taken. And people say to me, you know, I was always optimistic. Of course I was, because I knew all this was coming. I knew all this fantastic science was underway. This is a year ago or more now, as you would all remember when it all began. And now we're seeing delivery of all that promise. And it's a really wonderful example of science kind of engaging with a very serious problem and providing solutions to the problem that is COVID-19. And let's do more on vaccines, because obviously that's where the action is. Again, vaccines are the biggest contribution to human health in history, without doubt. They can be used for typhoid, meningitis, whooping cough, polio, chickenpox, measles. All of these were very serious diseases. Polio was paralyzing children in the 1950s. And doctors would see a polio victim come in and couldn't do anything for them. You know, the vaccine got rid of polio. Fantastic. No more children being paralyzed. And if you look here, on the left-hand side is when the pathogen is discovered. So the virus that causes polio, for instance, is 1908. I could talk about whooping cough or any of these. And then the green line is when a vaccine was discovered. It took a long time to get a vaccine for polio. You know, we still haven't got vaccines for malaria or TB. We have some, but we need more effective vaccines for those two. Really, really big diseases, you see. Go down the bottom. Look at this, SARS-CoV-2. Within sort of 9 months, we had a vaccine. And people ask me, oh, it was very quick, and are they safe? It was only quick because they put money behind it and people to work on it. That's why it went so fast. HIV is still no vaccine there, as you would all know. And that was a devastating disease, as you may, those of us who are old enough to remember when that happened. Still no vaccine. There are antivirals for HIV, but we need vaccines for these diseases because they're the best way. Prevention is always better than cure. That's, you would all have heard of that phrase. And this applies to infectious diseases as well. You're much better off preventing the disease in the first place. If you get the disease and there's therapies, that's good, of course, as I said, but the prevention is always better than cure. But this slide really captures the triumph of this. And then this next slide, and again, this is a striking one. I made this last week, actually, for another talk I gave. There was a thing called coronavirus vaccine tracker. These guys, they were in the New York Times, I think they were tracking the progress. And a year ago, there were no vaccines approved, okay? There were several different phases of testing. Look at this, fast forward a year, 8 vaccines approved. What a remarkable achievement. And still more coming down the track, by the way. So huge success for these wonderful sort of approaches to developing vaccines for COVID-19. And the other thing to say is, remember, they were all collaborations between universities and drug companies. They had to collaborate. Often the discoveries are made in the university because universities do research like my own lab here in Trinity, and then it takes drug companies to turn that into a product because that's what they're good at, drug companies. So again, very collaborative effort as well as the thing to emphasize. And this next slide really tells you what vaccines do. And this was made about a month ago, and I sent it out. I didn't make it myself. Someone made it. I can't remember who it was. I didn't get the citation, sadly, but this was made about a month ago. And I tweeted this out because I sent stuff out on Twitter. Only use Twitter for information, never use it for anything else. So I sent out a tweet on this. This had 40,000 retweets because it really captures how powerful vaccines are. In the unvaccinated population, many will be asymptomatic and have no real illness. Many will have mild disease, and that's good because it's, you know, we want to see as less disease as possible naturally. Some get moderate and some get severe and some die. Once you vaccinate, we all go blue. In other words, it's massively protective. Some will still have some mild disease and some will have moderate, no lethality. I mean, all the vaccines prevent severe disease and death, and that's the real success of them. You may still see some infections, but those infections won't break through into severe disease because the immune system stops it in its tracks and prevents that disease progressing into severe, you know, illness and then ultimately protects against death. That's the real triumph of vaccination. And of course, we have an Irish connection, Adrian Hill and Theresa Lamb in Oxford. They helped AstraZeneca. They made the vaccine for AstraZeneca. I mean, they went to AstraZeneca and said, will you please make our vaccine and distribute it for us? And of course, Adrian was knighted. And I had a collaboration with Adrian on malaria. He was actually a big malaria expert, he still is. My lab worked with his lab back about 10 years ago on malaria, for instance. So great triumph for many people. There's thousands of people involved in this, by the way, and it's nice to see Oxford and our Irish connection to be plugged there. And then, as you all know by now, 4 vaccines approved in Europe: Pfizer, Moderna, AstraZeneca, and Johnson & Johnson. 2 more to come. Novavax got a great clinical trial. Superb performance. That will be approved soon. Sadly, CureVac didn't work in the trial. Now they're trying to optimize that in various ways. That's a German vaccine, they may get that better. And then the Russian vaccine, Sputnik, that's a very effective vaccine as well. So we are going to see more vaccines as well as the 4 that we've got, which is tremendous. And, I would talk about this. You would probably see me and banging on about it. And a very nice thing was sent to me about a month ago. A little old lady in her 80s crocheted a little thing with hope on it, because of course what vaccines bring us is hope. It's a way out of this, is the vaccination campaign. And it's all about achieving a high level of immunity in the population. We're getting there. It's called herd immunity. The UK is almost there already. This blue line shows the UK. So in other words, we're getting to this 80% threshold, which means the virus goes away. And we're all confident we will have mass vaccination. Ireland, I think, is leading Europe in certain age groups now in terms of percent of people being vaccinated, which is great to see. And then the big questions we have are, and there's many scientific questions here. One is, how long will you be protected for if you're vaccinated? This is a cell type taken from a vaccinated person who had been vaccinated about 10 months ago, and they can find loads of these cells in the person's body. These are the cells that make the antibody. They're called plasma cells. And they could culture these from someone 10 months after vaccination, pumping out antibodies to beat the band. So in other words, we're going to get at least a year's protection from vaccination. It may go on beyond that. The tetanus vaccine lasts 12 years, for instance. So we are seeing really robust protection. We can anticipate probably booster shots like the flu in the autumn, in the wintertime, in the vulnerable, not everybody. We're vaccinating everybody just to get rid of the virus. As soon as we've done that, then we'll keep the vulnerable protected. And that's what the VISTA is. We're going to see booster shots. And the main reason for boosters is today's concern, and concerns keep cropping up, and are these variants. And there are 4 main variants now: alpha, beta, gamma. We know, and delta. We know how they've changed. There's a huge amount of information on these different variants. These are the amino acids changing if you're a biochemist. But the fact of the matter is, the 4 of them exist. Delta is the latest one. And they're only a worry if they're more transmissible, which they are. So they spread more, which is the concern, obviously, because they're spreading more easily. But much more importantly, can the vaccines protect against them? Now, they've changed. They're called a variant because they've modified through evolution. It's a random process, actually. Every time the virus divides, there's a slight mistake in the recipe for the virus, actually. And you might get one that's a bit different. And that one then might dodge the vaccine. That's the fear we have. The great news here is the vaccines are working. Now, they are spreading like wildfire. The UK is mainly green. That's the Delta form. Israel is less. Ireland, we've got about 20%. We can expect Delta to dominate because it's more transmissible. So it spreads much more readily. But here's the good news. This is from the UK, where it's running rampant. They know that lots of people now have had Pfizer or AstraZeneca in that population. And they've shown that 1 dose of Pfizer gives you 90% protection from ending up in hospital with the Delta. The second dose gives you 96% protection. AstraZeneca, 1 dose is 71% protection, 2 doses 92. These are very high levels of protection. The flu vaccine every winter only gives you 50% protection, and we like it, we use it. 71% is great for AstraZeneca. It's not as high as Pfizer, but it's still very high. And there's what I call confidence intervals around these numbers. These numbers have error bars, we call them. So in other words, that's given us reassurance. These vaccines will stop hospitalization. That's the main thing. You may get infected, of course, and you may be spreading it a tiny bit, but you won't develop severe disease. And that's what we want. The whole goal here is to limit severe disease developing. So we're optimistic now. Now, again, it's one to watch. These numbers are still being looked at closely, and the UK are releasing data all the time. Let's hope these numbers hold up. If the worst comes to the worst, we could vaccinate against these variants. And that's the ultimate end game in a way, is booster shots with variants. And that's all being planned. So we will get out of it, remember. All these variants do is they might push back progress a bit, you know, but we have a way to beat the virus, beat the variants through boosters, and boosters with variants is a sensible thing to plan for. And we're now telling everybody, get ready for boosters in the autumn. Not everybody, as I say, just the vulnerable and the ones who need the most of all is the idea there. There may be a universal vaccine. They're developing what's called a dream vaccine at the moment. This is the spike protein that we make the vaccine. The spike is what sticks into your lungs. The antibodies mask the spike and stop the virus getting into your lungs. They're making a spike vaccine that could work against any variant. So huge efforts going on basically to develop vaccines to beat variants. And that's where this is headed, I suppose, in the long run. Now, two more things I want to tell you about. And then this next bit is my own area in a way. It's an inflammatory disease. The lungs get inflamed. The virus goes in there. The immune system doesn't work properly. The tissues get very irritated by the virus and you get all this inflammation and then you can't breathe and we see the horrendous symptoms that then can emerge. The good news is therapies have got better. And even this time last year, they were better. Here's a graph from a year ago, but I still show it. This is comparing April to the end of June and it's percent survival. Look at this. And every age group, more people were surviving anyway across those age groups. Doctors got better at handling patients. They came up with new ways to treat them. And a very important drug was this, dexamethasone. That's an anti-inflammatory drug. And I worked on that as part of my PhD. That will suppress inflammation in the lungs. And then it's beneficial. It's kind of dampening down the inflammatory process. And a massive trial in the UK called the recovery trial. They've tested 6 different drugs in this trial. Dexamethasone came out of that. A second drug called baricitinib, which targets a piece of the immune system that I work on in my lab as well. And these are protecting people from the inflammatory process in various ways. We're going to see more data from that trial. There's more drugs in development. And I'm optimistic with it. Doctors will have 4 or 5 options to treat patients who develop disease. You might be wondering, why are people developing disease? Well, some don't respond to vaccines. And vaccines do break through. 96% means 4% of a risk of getting the disease, and they might end up in hospital. But now we can treat them. That's the beauty of this, is the backup, if you like. Some don't take vaccines, and that's fine. Vaccines should never be compulsory. Some can't take them for medical reasons. So in other words, we need treatments just in case we see people getting sick with this virus in hospital. And so this tells us our second plan of attack in many ways is therapies in hospital, and they are getting better, which is tremendous. Now, you don't want to end up in hospital. You're much better off having the vaccine or not getting infected in the first place. But still, we have that there to remind us that if you do end up in hospital, there's ways to treat this disease. Now, the last thing I want to tell you about, though, is your own immune system. Because remember, your best friend against this virus is your own immune system. Because we've evolved our immune systems over 100,000 years, remember, to fight infections. And it's very good. You wouldn't be here listening to me if your immune system hadn't defended you all through your life against infectious diseases to protect you, remember. And then secondly, it remembers. And when you get reinfected, it works really well against reinfection. And the vaccines, of course, train the immune system to recognize the bad guy, as I said earlier, as he comes into town or whatever, and then can be handled by that. So again, remember, your best friend is to keep your immune system active. And there's all kinds of ways we can all do that, remember. Good night's sleep is really important, amazingly. You wouldn't believe it. But if you have a bad night's sleep, the next day in your blood, there's 1/3 less immune cells. Your immune system gets tired as well. So try and get a good night's sleep. Stress is a massive negative for the immune system. And we all know this from our lives. If you're under stress, you might catch a cold or whatever it is. De-stress, whatever it takes. Read a book, meet a friend, have a little glass of wine if that's your thing. It's all okay. De-stress is very important. Good diet is really important for the immune system. We know a lot about diet. The immune system, different nutrients really help. A balanced diet's fine. If you're vitamin D deficient, take some vitamin D. If you're iron deficient, take some iron. Good evidence that these help, you know. And then exercise. Now, exercise is a de-stressor, but it's also really good for the immune system. The immune system likes nothing more than your blood pumping around your body to keep the immune system going, you know. So exercise is great for the immune system. And it's moderate exercise is best, of course, in this situation. So we can all do these things. We're not powerless against this virus. And as I say, only a tiny number get really sick. And it's often because they're in a vulnerable category, certain diseases, predisposed people to severe illness, or older people, because it's a disease of aging. So we do know, you know, where the risk factors are, and any of those people can help their immune systems to fight this virus. So there's all these things you can do to keep yourself healthy. I recently wrote a piece on iron and COVID, for instance. Ironing out vaccine efficacy. It turns out if you're iron deficient, the vaccines don't work as well. There's a reason why people wouldn't respond to vaccines, is anemia. That's been shown with other vaccines, not with COVID. We can predict that with COVID as well. So it's very important to remember all these things. There's vitamin D, the sunshine vitamin. All these different immune cells can, work better if they have vitamin D on board, which is tremendous. So again, keep your vitamin D levels up. Sunshine can achieve that. And then we might think about possible scenarios and how we're going to eventually emerge from this pandemic, because we all want to know that, don't we? How are we going to get out of this? And there has to be grounds for hope here for obvious reasons. First of all, some immunity builds up in the population anyway. If this was medieval times and there were no vaccines, this virus would have gone through our communities and would have tragically killed lots of people, older people and so on. The young people would develop immunity, and then they're now resistant, and then we carry on. That's the history of infectious diseases. We invented medicines and vaccines to protect people from getting sick, and that's what we did, and these vaccines are helping that tremendously. Even if they're only partly effective, they still make a big difference. So vaccines and natural immunity will combine to build up immunity in our population to fight this virus. And now the virus begins to go away, because the less hosts it has to grow in, the less it can spread in our population, you see. So those two things are very important. Remember, therapies in hospitals are improving all the time. Less severe illness and death because of therapeutics, which is tremendous. It's essential we get the vaccine to all countries. Now, why is that? Well, it's these variants. Every time the virus divides, there's a random risk of a variant cropping up that might be more troublesome based on transmission, based on making people sicker if they're not vaccinated. So we have to get rid of this virus as much as we can, not just in Ireland or in Europe or the US, in everywhere, because anywhere the virus is spreading, there's a risk of a new variant. That might come back into our country or somewhere else in the world and reinfect us and start causing problems. And our fear there is a really nasty variant. That's unlikely. We think the immune system can handle any variant, really. It's strong enough to do that. But still there's a risk. So we have to get the vaccine out to the developing countries. And I would be advocating nobody under 18 should be vaccinated until we vaccinated the vulnerable in developing countries. And many are saying that. And I'm a big fan of that, because there's lots of vulnerable people still in these countries who need vaccines. And people under 18, very mild disease. So ethically, it's an interesting question that, so get the vaccine out as much as possible. And all of these things combined, and the fear begins to dissipate. The end game to this pandemic is widespread vaccination, better therapies in hospital, and booster shots in the winter to protect people if new variants crop up or if immunity begins to wane a bit. Because even though I said it can last for a year, we still don't fully know. It might go off the boil a bit, so give a booster. And the booster really kicks things off. And even though the antibodies mightn't work as well against variants, because the variants are dodging the antibodies, the immune system is great at quantity. It can make so much antibody. The quality's gone down, but it's swamping the virus, swamping the variant. So again, booster shots can be, I would be advocating now. NIAC should be saying, get ready for boosters in the winter for the older people, just like flu. That's the real way out, because now they're protected in the winter for definite. You see, they don't get sick and end up in hospital. So again, that's the way out of this, really. And the fear begins to go away, thankfully. And of course, it's all about working together. Remember, and Ireland has done tremendously well here, because mainly we've been compliant with the public health guidelines, and the vaccination campaign has been tremendous. Very difficult for all of us, of course, and we've got huge sympathy for all the businesses and the people, and every age group's been affected by this. But we are now coming out of this, which is tremendous, and we must continue to work together to beat it as best we can and follow the guidance. The government have a really tough job this week to decide on this 5th of July thing. I've got sympathy for them, because they won't win either way, but still, if we all just row in together, we will beat it in the long run, is the idea. And then this last slide, this is Tony Fauci. He's the key immunologist in America, and I know him quite well. I spent 6 months in his institute, actually, back in 2009, all those years ago. And he keeps getting asked, are we there yet? We're not there yet, but we're getting there. And if we keep doing the things we're supposed to be doing, we follow the vaccination campaign, we will finally get there in the end and learn to live with this virus into the future. And then hopefully, if another virus crops up, people often ask me that, we'll react much better the next time. Watch. And the fact that we can make these vaccines so quickly is a huge testament. And if another virus comes along, we can make a vaccine very quickly to beat it. So again, all of this tells us that we are going to get there in the end, and we will come through this pandemic. And this will be a great day for all of us in so many ways. So I'll finish there, and thank you for listening. And I'm happy to take any questions.
Thanks a million, Luke. That was really, really interesting. We do have a few questions that have come in so far, so I'll kind of start with the first one. The first one is from Alice. And the question is, the Delta variant is highly more contagious than the Alpha variant. Is washing your hands and masks still the best way to protect yourself?
Masks for definite. Yeah, I mean, it's interesting this. So the evidence that it's spread on surfaces lessened, because early on we thought it was like flu in this regard. Flu is often spread on surfaces because big droplets come out and land on the surface. You put your hand down, you touch your face, you catch the flu. Amazingly, this has been known for decades. So wipe a surface down and you get rid of the flu or the virus off the surfaces. For example, washing your hands because you could be touching things and all that. Now, it turns out that there's not much evidence that it's on surfaces. So it wouldn't surprise me they'll change that guideline. No need to wash your hand. Now, they aren't saying for the moment because it's not 100%, but the guideline might change and hand washing won't be as needed. Of course, we'd be wise to wash your hands in the winter to stop flu spreading, by the way. There was hardly any flu this winter because of all these measures we were doing anyway, So washing of hands and surfaces is probably less important. What's very important is this virus spreads on infected air. Keep that in your mind. You catch it off the air. And the evidence grew and grew and grew for this. It began to grow about a year ago, actually. By the time we got to 6 months ago, it was very clear people catch this from the air. And if I'm speaking, and even speaking does it, right? The virus comes out of my mouth and it floats on the air like a little feather. I can go anywhere in the room. And stagnant air is deadly for this virus because it just floats on the air and you breathe in some of that stagnant air and you get infected. And that's how it spreads, right? Now, what does that mean? Well, ventilation is critical. And in fact, ventilation is the #1 mitigator now against this virus indoors by far. And all the evidence supports that. We've got great evidence to say that's the case. So any workplace environment, then we've got to be sure there's good ventilation. And mask wearing, secondly, because if I'm wearing a mask and I'm talking, the mask is trapping the virus. You don't need to be an epidemiologist to figure that one out. And then we protect each other by wearing masks. Now, where do you wear masks? Indoors where there's crowds, right? Now, if you're vaccinated, you don't need to wear a mask. Now, we haven't given that instruction yet, but we're moving in that direction. Now, Israel, they're a good example. They recently said no need to wear masks anymore until Delta came along. Delta is more transmissible, so it makes sense to put the masks back on while Delta's in the environment. Now, the other thing to say would be is this. We know the vaccines are stopping transmission by at least 50%. So simply by being vaccinated, then you're half as likely to spread the virus if you pick it up. Now, people often ask me, well, if these vaccines are so great, how can I be infectious? I'll tell you why. The vaccines are great at bringing the immune system out in your lungs, okay? Because you inject it into your arm, the immune system is in your lungs, and if the virus goes to your lungs, which can kill you, remember, the immune system kills it. That's why you don't progress to severe disease. It's less effective in the nose. So in other words, the immune system can't quite get to the nose. So the virus now can grow in your nose. It won't go to your lungs. If it does go to your lungs, it won't make you sick. But the trouble is a bit in your nose and you might release it then and infect someone. And that was the concern we had. But the good news now is, guess what? These vaccines are so powerful. The immune system does get to your nose and does limit the virus there. So in other words, it is preventing transmission, but it's probably 50 or 60% decreased transmission if you're vaccinated, which is still very good, remember. But still, because of the Delta, the advice would be for the moment, it makes sense to wear masks in this indoor setting. Outdoors is safe. Remember, if you're vaccinated and outdoors, that's fantastic. Because even if you have a tiny bit of virus in you, if you're vaccinated, it'll blow away immediately. And a lot of this, actually, to be honest, the key factor about getting infected is the dose of the virus. If someone is beside you and they're full of virus and you pick up a high dose, then there's a good chance of you getting infected. You see. A low dose, you mightn't get infected. And if you're outdoors, the wind dilutes the virus. The dose goes right down outdoors. That's why outdoors is such a safe place. And secondly, ventilation, of course, is like being outdoors anyway, because you're blowing the thing away, So that's why that's really good. But as I say, and the mask decreases dose. That's one benefit. Masks aren't perfect. Anybody who wears a mask and has glasses on, they steam up. So the virus will get out a bit, but it's reduced hugely. You're decreasing the dose by wearing a mask. That's why masks are so effective. Their main job is to decrease dose, really.
Okay, the next question then is from David. So is it possible that future variants will be weaker and less transmissible? That's the hope.
I mean, we don't know is the problem. I mean, the best virus is one that doesn't kill you because there's no point killing the host. The virus live inside us, So very often viruses become more benign because they want to live in you, and grow and develop and spread to someone else. The common cold is a great example. And that's a coronavirus. There's 4 colds are caused by coronaviruses. And they're very mild diseases. The hope might be that it would become more benign. We just don't know for the moment. It's a bit random. The virus doesn't really care as long as it spreads, I suppose. So if it can get away with spreading and making you sick, but it's more optimum if it makes you less sick. So we're hopeful that it might turn into a more benign version of itself.
Yeah, I think the next question is around the ethical responsibilities, and I think you touched on it, but it is kind of an interesting thing, especially for a lot of people here on the call, because we work in the not-for-profit sector. So the question from Kate is it crucial that we work to help other more vulnerable countries to help prevent variants along with our ethical responsibilities?
Indeed, it is. Right. Yeah, I mean, there's kind of there's a self-interest thing mixed with altruism here in a way, because we don't want these vulnerable countries getting really sick. I mean, look at India. It was a disaster. India, no oxygen. It was awful scenes there. We all remember them. So got to help them, because there's a lot of vulnerable people there, a lot of older people not getting vaccinated, lots of healthcare workers. Amazingly, there wasn't enough vaccine to give it to healthcare workers even. So we've kind of an ethical obligation to help the vulnerable when our vulnerable are protected. I suppose that's a selfish way to look at it, but certainly we protect our own vulnerable. Any vaccine left over, give it to the vulnerable people there. That's the argument, And as I said earlier, why would you give a vaccine to a young person who's not at risk of severe disease when there's someone who is at risk of severe disease in a different country, So there's a strong ethical argument there. WHO have said this, by the way, don't be vaccinating young people. Give your spare vaccine away to developing countries where there's real need here and a lot of suffering going on. So I do think there's a strong case for that. The case against it would be young people still get sick, and not as many, but some do get ill. And vaccinating them will decrease transmission in overall and get rid of the virus entirely. So it's a balancing act there in many ways. I think in this phase of the pandemic, though, we should really consider giving the vaccine away to people that really need it once we've done our own vulnerable groups, really.
And do you think we are? Are we doing that?
Well, to some extent, yeah. I mean, there's no doubt America's given 500 million doses, for example, as part of this COVAX thing. So I think we probably are. And Europe, EU has agreed to as well to give away. Every country has the EU will have surplus supply if you vaccinate everybody over 18, for instance. So they are pressing for that. I think it's a bit of a political thing in a way.
Yeah, it just seems like a no-brainer, but
it does, doesn't it? I know. Yeah.
Okay, the next question is from Anna. So it's the question is: are there any particular indicators for long COVID?
That's the next thing. I didn't really discuss that much. I mean, long COVID is real, as we all know. We know people who've had long-term symptoms. It's hard to get a percentage on it, quite how common it is. We think it's more common in people over 50, and women are more at risk of it than men. In the over 50 group, there's several studies have shown that could be hormonal. There could be various reasons for why that would be. But it's quite hard to get a fix on it. And obviously, can you predict it? No, you can't. It seems to be very random. Like most things in health, in some ways, some people, it could be dose of virus might be part of this. If it's more severe disease, it could be more likely to develop. We think we know what's going on with long COVID, by the way. There's two options here. One is there's remnants of virus still in your body that still are kind of burning away and giving you symptoms. And there's evidence for that, actually. In other words, the immune system hasn't managed to clear it all. There's pockets of resistance, if you will, still fighting, and that gives you symptoms, And then the second reason could be you've reset your immune system. In other words, when you have a massive immune reaction, all your immune cells are firing on all cylinders, and they don't quite go back to normal. Even though the virus is gone, they've been reset, and now they're a bit more active, and they're giving you some of the symptoms. They're the two options. The good part of this story would be there's anecdotal evidence that vaccines can correct long COVID and relieve some of the symptoms. There's a massive trial running in America at the moment to look at that very question. That was anecdotal, just people reporting they felt better. But now there's a real trial running to see if that's true. But it's going to be tremendous, because it's a great reason to take the vaccine, by the way, isn't it? Let's face it. And maybe you'll develop long COVID 6 months' time. Vaccine might give you relief there, So again, it's a very active area of research that we're hoping we'll see progress on it.
Yeah, there was a couple of questions just coming in there on that. And I suppose just one question of how do you support people with long COVID then? There's so little research, what can what can we do to support
the
people?
challenge is very heterogeneous, by which I mean you'll have a different set of symptoms, And the main symptoms are fatigue, breathing difficulties, what's called brain fog, which is trouble concentrating. They're the main ones. So then you do get much more sort of troublesome things like heart problems, all sorts of things, But each patient might be slightly different. So So it's quite different, and that can be all kinds of reasons. It could be where the virus lodged in your body might be causing differences. It's quite obviously not a complicated thing, you know. And there's no obvious treatments. I mean, let's face it. Remember, they've known about this before. It's called post-viral fatigue syndrome, well known already. It's a thing called ME. You may have heard of that. They're all part of the same family of diseases. They often happen after an infection. Lyme disease is the big trigger for this, for instance, which is caused by bacteria. That's got a relatively high incidence of long-term symptoms, you know, and it's just very difficult to treat. We need more research. The good thing about COVID actually is we may get treatments for other types of persistent symptoms post-infection, which would be tremendous, because I mean, the current numbers in long COVID, at least 10% have some kind of long-term symptoms. So it's a very serious burden, you know. Yeah. And long COVID, or COVID itself, and isn't just about people dying, it's also about people recovering and having long-term problems, you know. So we need to treat those as well. We need to have ways to manage those clinically too.
Okay, the next question is from June, and it's a question around, so she has received both her vaccines, but has nieces and nephews in their 20s. And is there additional precautions you should take? I suppose you kind of answered that in one way, but is it around like the mask wearing, try and stay outdoors if you're around particularly young people?
Well, the Delta thing is changing it slightly, you see, because obviously we've a more transmissible virus among us. So that makes things a bit more difficult because they're going to spread more. So the current advice, though, if you're fully vaccinated, you can meet up with unvaccinated people and behave normally, you know, outdoors, indoors, everywhere. If the person you're meeting is a younger person who might be vulnerable, though, and they haven't been vaccinated yet, then you might be slightly cautious, just in case you're going to infect them. Given this, the risk of you being infectious, as I mentioned already, is very low. Let's say it's a 60% decreased risk, there's still a slight risk of you infecting them, you know. So we've still got to be slightly cautious in this phase until everybody over 18 is vaccinated, really. But remember, if that young person gets infected, there's a tiny chance they're going to get severe disease because this is a disease of older people or vulnerable people, and we know that now. I mean, if you're under 18, it's almost no disease. It's very mild. Now, a tiny number will get it, but that's a risk. Everything comes with a risk, remember. We can't live our lives worrying the whole time either, you know. But the risk of infecting a young person and them getting really sick is tiny, you know. And if you've been vaccinated, the risk of you passing it on adds to that tininess in a way, you know. So I think in general terms, the advice would be if you're fully vaccinated, you can operate pretty normally. You know, you can meet people indoors and outdoors and so on, but maybe limit it slightly, you know. Try and outdoors is great, you know, stay as long as you like outdoors. If you're indoors, maybe limit the time a bit, just for this phase of the pandemic, really, you know. Again, use your common sense in a way, you know, because obviously it will come down to personal choice in the end.
Yeah. Okay, the next question is from Austin. He says, thanks, it's very optimistic and informative. And do you think that COVID will become a global class illness, so long-term illness, due to the lack of urgency and support for nations most at risk and in greatest need?
I think it'll become an endemic disease. Let's start with that. So we're not going to get rid of it. We've only ever got rid of two infectious diseases, smallpox and polio, and even polio is not fully eradicated yet anyway, you know. So any infectious disease is inclined to be somewhere, you know, it's burning away somewhere on the planet. And then you get upsurges now and again. Measles is a good example, you know. So the vaccination works great against measles, but because of the risk of MMR and measles and autism, the use of measles went down, and there were spikes of measles, you know what I mean? So there was always the risk of it coming back. So what that means is it'll be very hard to fully eradicate. It could well be lingering in countries that can't get access to vaccines, hence our focus on those countries. I think there's such a focus on this disease, though, and there's such a focus from COVAX and all the organizations that whose job it is to get vaccines into developing countries. We could well get the numbers right down in those countries. Wouldn't it be tremendous? So I think the aspiration has to be to get the virus right down as much as we can all over the world, you know, and then let's see where that takes us. And then every winter we'll vaccinate just like flu. You know, we'll give the elderly, we'll give vulnerable groups the COVID shot. In fact, it wouldn't surprise me, and it's in development already. Novavax, for example, are putting the COVID vaccine in with the flu shot in the one jab. That's got to be sensible for the future, you know. So again, if you fast forward, maybe even this winter, if we're lucky, certainly the winter after, things are going to be pretty normal, and all we'll have is, you know, booster shots every winter for people, and then occasionally there might be an outbreak here and there, because it might be still there in South America or somewhere, and now it'll begin to go up again. And because of travel, that might come into Ireland. And I mean, one projection that we're having is, you remember in previous winters, there was trolleys in hospitals with people with the flu. Some of those will have COVID in the future, you know, and then we can treat them, thankfully, with these medicines stuff that I'm talking about, you know, the stuff I'm getting really sick, you see. So that's what the future probably looks like with this.
Okay. And the next question is, what's the evidence around someone who has had COVID previously getting it again?
Yeah.
Or and is there any way of finding out if you've ever had it?
Yeah. The data got good. So as you can imagine, what's happening now is we're seeing immunology in real time in a way, you know, and they began looking at closely to see if you were infected, what your risk of reinfection was. And they could follow people, you know, the people who are definitely positive, then they followed them, right? And if you've been infected, there's an 85% decreased risk of reinfection. That's the top line number we got from all these studies. That's as good as a vaccine. Remember, the vaccines are decreasing risk by 80, 90%. Natural infection is the same. And then second, the thing is, we don't know how long that'll last for. That's what we don't know. Like if you go forward a year from now, that'll begin to wane a bit. And then maybe it'll go from 85 to 70 to 60, something like that. Although it could last longer, we don't know. And I wouldn't worry about that for the moment. All that we know now is a single bout of infection will give you 85% protection from reinfection. Now, the trouble is that might vary by age. It might vary by health status. It's a top line number, you know. But still, it's a good number to have in your back pocket, kind of thing, that protection. And then even more compelling, if you get vaccinated after being infected, you get a massive protection. And like the highest levels of antibodies they've detected in humans is someone who's been infected and then had one shot of Pfizer. So it's almost like as if the natural infection is like your first shot. And then your first shot becomes your second shot. And that's giving huge protection. And in fact, it wouldn't surprise me, they'll change the guidelines on this and say, if you've been infected, you only have one shot anyway. There's no reason to give a second shot if you've been infected. So that's all really good news as well. What's amazing about it, the good news on vaccines grows every day, you know, from multiple sources. Don't follow the conspiracy theorists, because we've multiple sources back. If you're a scientist, you want multiple sources giving you the information. Lots of studies have confirmed a single bout of infection followed by one shot gives you massive protection. It's great, you know. So that's the way to think of it. And as I say, we may well move to a scenario whereby if you get evidence that you're infected, one shot will do. Now, what's the evidence you've been infected? That's hard to show because the antibodies will wane. So what happens is, if you're infected, the immune system wakes up. That cell type, that wonderful picture of that cell, remember, that grows and grows and grows and grows. You have more of them in your body, and they're making the antibodies, and then you have loads of antibodies. The trouble is, the antibodies do their job, the virus goes away, and then everything begins to calm down. There's no point in making antibodies if you've no virus on board. That's very wasteful for your body. But those cells don't go away. They go into your bone marrow and they wait. Isn't that fantastic? And they wait. And now if you get infected, there's lots of those cells there. They've expanded during the first infection or the vaccine. There's more of them. And then they wake up with a vengeance and they kill the virus before you even know you've got it. That's how the vaccine and the natural infection works. Now, so in other words, if you measure antibodies, that might be that informative. If you can measure those cells, that's very informative, but they're very hard to measure. You got to take a bone marrow sample, you know. So it's quite hard to prove actually that you've been infected. Tricky, but you can in 2 or 3 months after, because you're still making antibodies for probably 2-3 months. You can measure those in the blood, but by the time you get to month 5, 6, 7, those antibodies have waned because you don't need to make them. Otherwise, your blood will be churning with antibodies from every infection you've ever had. You know? The immune system isn't designed to be that way. It's designed to get the cells to be trained, you know, and now they're ready. It's a bit like an army whereby you train the troops to fire a gun, you know, and they fire the gun and then they go back to the barracks and then they wait, you know, and then they wake up again and begin firing the gun again. The bullets are the antibody, you know. That's the way to think.
Yeah, I think like just what you've been saying there brought up a load of different things, including like we've just been bombarded with so much information. I think just like from the general public point of view, that it can be really hard.
Oh, yeah.
I think, you know, things like this and speaking to other people and other, like, I suppose this is what you've done for the last, as you said, 35 years.
Yeah.
So, you know, to rely on the science is
yeah, it's an important question. I understand people are hesitant and reluctant. They worry about vaccines. It's all understandable. These are brand new vaccines sticking in your arm and all this sort of stuff, you know, so it's natural to be anxious about it, you know. And all I can do and my other colleagues is just get the information out there as we see it, and then people can choose themselves. You know? I mean, here's a fact about vaccination. If you read stuff on Google or whatever that say don't take a vaccine, it's a free world. You can follow that advice if you like. 96% of all doctors have now been vaccinated in the US and Europe, 96%. So those doctors are saying, give me that vaccine. Who do you believe, your GP or your medical advisor or someone who is not an immunologist? Let's put it that way, you know.
Okay, questions are coming in hard and fast, so I'm going to try and get through a few more. So do you think all vaccines will be made more widely available to different demographics kind of as time goes on?
I hope so. I would love now tonight, talk about a week that we're going to get a couple of big announcements this week, right? So we're hoping NIAC, the Advisory Committee on Vaccines, we're hoping they will say AstraZeneca, Johnson & Johnson for all age groups. And it'll be a scandal if they don't say that, because the reason why we didn't give AstraZeneca to younger ages was this risk of clotting. That was extremely rare. The great statistic there is you're at a higher risk of getting a clot from AstraZeneca driving to the vaccine center than actually getting clots from the vaccine. You know, the risk of getting an accident on your way there is higher. So in other words, it's very low risk. And in fact, it's not true that younger people are at lower risk, because across all ages are equally at risk of this clot, and it's very rare. So in other words, there's no reason not to give it to young people based on age and risk of clotting. So they should give that vaccine to everybody over 18, especially with the Delta variant out there. It's spreading like wildfire in that age group. You will end up, and there's a risk of you ending up in hospital with Delta if you're unvaccinated, you know, at any age group. So therefore, it makes sense now to protect those younger people with those vaccines, because they will protect against hospitalization. That's what I said, that's 71% protection, one shot, you know. So the hope is they'll change the guidelines, and that if they don't, we will have millions of doses of those vaccines on the shelf, which is ridiculous because it's a weapon to give people to protect them, you know. So we're hoping that'll change. We're also hoping they'll change the guidelines on allowing Pfizer to be used as a second shot after AstraZeneca. It's called heterologous vaccination. You change the vaccine for the second shot. That works great. A big study just came out on Friday in the Lancet showing it's safe and efficacious to mix and match, you know. So again, now why is that important? It speeds up the vaccination campaign. You're not waiting for the same one to come in a second time. And then secondly, Pfizer's a really strong vaccine for the over 60s. Let's give them, they've been messed around, you know. Let's give them Pfizer as a second shot. So now I suspect they won't do that. Watch. We'd have a gamble, right? Put money on it. What will NIAC say?
If you want to put a bet on and the donations go to Depaul.
Well, exactly. We should have a sweepstake. But I don't know. I suspect they'll have to allow AstraZeneca and Johnson & Johnson for the younger age groups. If they don't, they're making a big mistake. Will they say Pfizer for the over 60s? They mightn't, because there could be some logistical reason why they can't do that. I'm hoping they will, though. Let's see what they say.
Yeah. And there's a couple of very specific questions. So there's one question, is there any truth to women having more issues from having the vaccine, like menstrual issues, say, than men? Is there truth to that?
Well, men don't menstruate.
Oh, yes, sorry, yes.
You don't know. There isn't any worries about that. There are anecdotal reports of that happening, actually. So, okay. But statistically, the trouble with this is, and it's understandable, let's say a woman has the vaccine and notices that her menstrual cycle changes. That could be for any number of reasons. Yeah. Menstrual cycles change for all kinds of reasons. If you look at 100,000 people, there's no link to a disturbance there at all, which is good.
Okay.
There's also no link to fertility issues, or all that stuff was rubbish. You know, that was spread by the anti-vaxxers. You know, that idea. So no, there's no need to worry about those sorts of things.
There's another very specific question around, have you ever heard of any upper back pain as a side effect from Pfizer or any of the vaccines? You
do get side effects. It's the strangest thing. We're all different, remember. All of us have different faces. We've also got different immune systems. It's like tiny differences between us. That's biology in action in a way. Some get side effects of all kinds. You'll see every possible side effect reported after these vaccines. And remember, I'm not trying to say this is the reason. That person could have pulled a muscle that day in their back. You know, there could be other reasons for these things, or it could be the vaccine. Either way, the evidence is so compelling. All those side effects resolve within a day or so. In most people, now some might go on a bit longer. If you have any side effects, talk to your GP. That's always the advice, just in case something's going on. You know, we now know so much about these vaccines. I mean, so in the UK now, 50% have had 2 shots of either Pfizer or AstraZeneca, and they've looked at all those people. And we know there's nothing untoward happening with the vaccines. We knew from the trials already, but now in the field, we know these vaccines are safe and efficacious. But any kind of side effect, if you worry, it's always worth just give your GP a ring and they'll reassure you.
Yeah, look, we're on to the last couple of questions, and I have one as well for myself. But you mentioned just before kind of what is the protection of if you've had COVID and then getting one additional vaccine, and that would be the same age. What,
Yeah.
like, that's not being done in Ireland at the moment, is it?
No, I mean, the question, the studies, the science is saying that basically at the moment, you know, that a one shot will suffice if you've been infected. But they haven't approved it anywhere yet, but they may well do. There's talk in America of them changing the guideline on that. The only issue is you got to make sure you were infected, you see. So there has to be evidence for that to allow that to happen, you know.
Okay.
Now the third shot becomes a booster anyway. So they may well say, oh, we'll take a second shot, you know, in the winter. You know, you may see that as well, you see. I suspect it'll be a lot more flexible. So once we have massive supply, I mean, in America at the moment, you can walk into a Walmart and there's 3 vaccines on the shelf. You can pick one, you know, and get the vaccine that day if you wish, and get a second shot 3 weeks later if you want, you know. So we're going to see a lot of flexibility will come into this, I predict.
There's then, so there was a question around young people, but I think you've answered that. It was around, you know, is there much gain from vaccinating young children?
Yeah, well, you see, as I said earlier, there is a gain, there is a risk of infection in young children, and there is a small number might get severe disease. But the numbers are tiny, you see. So again, if you're trying to weigh up 2 things here, vaccinate someone in their 60s in, say, Brazil or whatever, to pick that randomly, some country where there isn't enough vaccines for older people, versus someone who's 12 here, you favor the one who's more vulnerable. You know, you favor giving it to them ethically again. Is the thing.
Okay, we have one last question, and it's non-COVID related, which I'm sure you'll be delighted to answer a non-COVID related question.
Lord.
So going back to your statement around arthritis being an inflammatory problem,
yeah.
Is the cause unknown for all autoimmune disorders?
It is. That's the biggest mystery. We've got the top 5 questions in immunology. One of them is, why does the immune system begin to think your knee is foreign and begins to attack it? You know, or your brain is, you know, MS. You get destruction of the myelin sheath over there again. The immune, and it's amazing. If I take a sample from an arthritic knee, it's full of the immune system. It's full of antibodies. It's just like a COVID lung. It sounds a bit strange, but it's the same troops. Remember, are in both places. We think of autoimmune disease as a civil war, where your troops turn on your own country, kind of thing. Whereas COVID is a war against an enemy, you know. But it's the same truth. But it's the biggest mystery we have. There's various ideas now. They think it could be partly genetic. Some of the immune genes are a bit different, and they're triggering a response. There could be an infection that kicks it off and triggers it. We'd love to find an infectious reason for rheumatoid arthritis, because then we could develop a vaccine against it, you know. So that's like Lyme disease can progress into rheumatoid, and that is caused by a bacteria, you see. So, but by and large, what causes autoimmunity remains a mystery.
Okay, well, look, we'll finish up there. I think that was all the questions. I just had one more question for you. I suppose for you personally, what has been the biggest learning over the last kind of 14, 15 months from a COVID point of view?
That's a tough one, right? The biggest learning is avoid the media. No, hang on. The biggest learning for me, well, I suppose I was blown away by how these vaccines panned out, because I thought it might take longer. You know, we all thought we'd be lucky to have one now. You know, we had one last November. So when Pfizer reported that first trial, it was a great day for us all. I remember vividly when Pfizer reported 95% efficacy, couldn't believe it. So what we learned from that was these RNA vaccines are tremendous, you know. And remember, there'd never been an RNA vaccine approved before. They're called RNA vaccines because what those vaccines have is the recipe to make the spike protein is the RNA molecule. That's a recipe basically made from this thing called RNA. And that had been never done before. So we were all amazed at how fantastic it was, really. And we were hopeful, obviously, with our fingers crossed. So the biggest thing I learned was RNA vaccines are superb. And what that means then is we will see more vaccines. Now remember, malaria is still out there. TB is still out there. HIV. Will we reach the ultimate dream of immunology, get a vaccine for AIDS? That'd be tremendous. And obviously, we've got treatments for AIDS, which is brilliant. But a single shot vaccine to prevent AIDS would be superb, especially with the developing world, because they can't get the drugs to those countries either. You know? So now all the drug companies are developing RNA-based vaccines against many different diseases. And the ultimate holy grail, right, is cancer, by the way, because, you know, cancer is an alien in your body as well. You get a tumor. It's a bit like an infectious thing. The immune system can kill tumors. And the latest breakthrough in cancer research is to get the immune system to kill tumors. They're called checkpoint inhibitors. And they work well in certain people. You could get a vaccine for cancer. Wouldn't that be brilliant? And the ultimate dream then is a vaccine for infectious diseases that we need vaccines for, but also against tumors, because then you'd have a great way to treat cancer. Because the immune system is brilliant at killing. You know, some people spontaneously go into remission with cancer. That's because their immune system, for some unknown reason, wakes up and can kill the tumor. You know, so again, there's lots of optimism now around vaccination going beyond COVID. In fact, the biggest thing we've learned overall is lots more information about the immune system that could be deployed against other diseases, and that'd be really brilliant. That'd be a great legacy, wouldn't it?
Yeah, it's something we don't, I think, because we're, as you say, just listening, you know, to the media quite a lot and how it affects us. I think if you think longer term, around the change for science in general.
And the other, by the way, while we're at it, I should have mentioned, Mairead, the Johnson & Johnson vaccine was great for homeless people, remember, because it was a single shot vaccine, which is really useful. And Ireland did very well there. You know, we got that vaccine out to that community quicker than other countries, which was tremendous. You know, so again, that's another example, I suppose, of how we can get our act together when we choose to, in a way.
Yeah.
Maybe that's the learning, is it? Maybe if you put your mind to something, you know, and we all work together, we might make progress. You know, and that Johnson & Johnson vaccine in the homeless is a great example.
Yeah, well, look, I think that's a good place to finish. We've answered everyone's questions, so we'll wrap it up there. Look, thanks a million. I know, as you said, you're extremely busy at the moment, a big week for COVID and announcements stuff, so really do appreciate it for your support for Depaul, and then thanks for everyone else for asking questions and engaging in the conversation. So
no problem, right? Always happy to help Depaul, as you know. I'm very happy to answer those questions. Thanks everybody for tuning in.
Thank you so much.
Right.
Bye.
Good stuff. Thanks, Mairead.